Hello everyone, so today we are going to start with the fourth video of the series, which is thalassemia. Imagine there is a factory where hemoglobin is being produced, and that factory has different workers, and those different workers are responsible for making different chains. But in thalassemia, some of these workers turn out to be faulty, which leads to faulty chains, and hence production of hemoglobin is being reduced. Now, these workers are analogous to the genes, and the faulty workers are analogous to the defect in the genes or the germline mutations, which lead to decreased synthesis of alpha globin or beta globin chains. Now, what are alpha globin and beta globin? We know that hemoglobin is made up of 2 alpha chains and 2 beta chains. And when alpha chain is affected, we get alpha thalassemia, and when beta chain is affected, we get beta thalassemia. Therefore, when less globin chains will be produced, the formation of hemoglobin will also be less, and there will be decreased oxygen carrying capacity of the blood. This will lead to hypoxia. This is our first point. Now, if beta chains are low, then alpha chains will accumulate, and if alpha chains are low, then beta chains will accumulate. Now, what happens is that excess number of chains are toxic. This deposition will lead to hemolysis, and it will damage the RBC, causing anemia. So the two important features of thalassemia are hypoxia and anemia. Now let's look into the genetic features. So there are 2 chromosomes, chromosome 16 and chromosome 11. The alpha gene is present in chromosome 16 and the beta gene is present in chromosome 11. Now there are 2 alpha genes per chromosome. So total there are 4 alpha genes present. Hence there are 4 workers. So if you even lose 1 or 2 workers, there will be mild or no effect. But we have only 1 beta gene per chromosome, so total we have 2 beta genes in 2 chromosomes. Hence, there are only 2 workers, and even losing 1 worker will be a great loss for the factory. So this was the basic concept of thalassemia, and now we will be moving on to the details. Thalassemia is quite prevalent in areas like Mediterranean Basin, Middle East, tropical Africa and Asia. But why this prevalence? Because heterozygous carriers have a special protective ability against malaria. We know that malaria is caused by a parasite called Plasmodium. This Plasmodium treats the red blood cell as its house. It enters, it grows and it multiplies inside the RBC. But in thalassemia, what happens? The RBC is microcytic, it's small, it has less hemoglobin and it has an unstable membrane. So basically it is a bad quality house. So less hemoglobin means less nutrition, and high oxidative stress is toxic for the parasite. So it struggles to survive. And the infected RBC is destroyed even before the parasite completes its life cycle. Now let's learn about beta thalassemia. So in beta thalassemia, we can either have reduced number of beta globin genes, and we can denote it as B superscript plus, and we can also have absent beta globin genes, which we can denote as beta superscript 0. But why do this happen? They happen because of several mutations. Mutations like promoter mutations, splice site mutations, and frame shift mutations. Promoter mutations results in defect in transcription. Splice site mutation results in abnormal messenger RNA, and frame shift mutations results in defective proteins. Now, frame shift mutations will lead to absent beta globin chains, and promoter mutations will lead to reduced beta globin chains. However, the splice site mutations can either result in reduced as well as absent beta globin chains. Now, this impaired beta globin genes can lead to anemia through 2 mechanisms. As the number of beta globin chains have decreased, therefore synthesis of hemoglobin will be deficient. Hence, the RBCs will be hypochromic and microcytic. And also there will be subnormal oxygen transport capacity, which will lead to hypoxia. Hence, under the microscope, we can see that the central pallor of the RBC is more than 1/3. And the other mechanism is diminished survival of red cell and precursors, because there is an imbalance in the alpha and the beta globin synthesis, and when one of them accumulates, it leads to hemolysis. But why does hemolysis happen? See, in our hemoglobin, we have 2 alpha chains and 2 beta chains. Now, when the synthesis of beta chains decrease, the number of unpaired alpha globin chains will increase. Now, inside the RBC precursors, this unpaired alpha chains will aggregate, and it will lead to membrane damage, which can further result in apoptosis. Now, what happens to RBCs which survive the marrow but they still have alpha chain inclusions? Their membrane becomes rigid and damaged. Now the spleen will recognize the damaged cells and hence the RBC destruction will take place in the spleen. This is known as extravascular hemolysis. All this will lead to severe anemia and hence as a compensatory mechanism there will be an increase in the level of erythropoietin. This will lead to bone marrow hyperplasia as it will be trying to make more and more RBCs, hence the marrow spaces will increase. This will lead to bony deformities. But why does extramedullary hematopoiesis happen? This happens because marrow is itself insufficient. So body will activate liver, spleen, etc. to produce more and more RBC outside the marrow. This often leads to organ enlargement. Now let's see why ineffective erythropoiesis cause excess absorption of dietary iron. So when the erythropoiesis is ineffective, it suppresses hepcidin. Normally hepcidin has an inhibitory effect on iron absorption. When hepcidin itself is suppressed, what will happen? Iron absorption from the gut will increase. Hence there will be an iron overload. This is known as secondary hemochromatosis. This is very commonly seen in thalassemia patients, and mostly the heart and the liver are affected because the iron starts depositing in these organs. Now, what are the types of beta thalassemia? The three types are minor, intermediate and major. In minor beta thalassemia, one beta gene is completely fine and the other one is mutated. So, this can be either asymptomatic or we can have mild anemia along with slight red cell abnormality. Next we have intermediate. Intermediate can have various mechanisms and it shows severe anemia, but the person does not need regular blood transfusions. In major beta thalassemia, both the beta genes are mutated. So the anemia is severe and along with that the person needs regular blood transfusions. Now let's come to the morphology. We can see that the RBCs are of different sizes and shapes. Hence anisocytosis and poikilocytosis are present. Then the next feature is small RBCs, which means microcytosis is present and also hemoglobin is less in amount, hence the RBCs are hypochromic. We can find target cells here. How can we identify target cells? We can see that in target cells hemoglobin is in the center and the pale ring is on the outer ring. We can see reticulocytosis in the bone marrow and also sometimes nucleated RBCs can be seen. Now, as the bone marrow is trying very hard to compensate, there will be new bone formation in the facial bones and the skulls, and we will get to see a crew-cut appearance in the X-rays. Next, due to extramedullary hematopoiesis and phagocyte hyperplasia, there will be enlargement of the liver and the spleen. Due to iron overload, hemosiderosis and secondary hemochromatosis are very commonly seen in thalassemia, and the treatment is chelation. Now let's look into the clinical features. The thalassemia patients have a typical facial structure known as chipmunk facials. This chipmunk facials happens because cheekbones and other bony prominences are enlarged and distorted due to bone marrow hyperplasia, right? The other features are hepatosplenomegaly, anemia, iron overload, secondary hemochromatosis, which leads to heart complications. Now, what are the treatments? The treatment is, first of all, primarily transfusion of blood. Then we have chelation for the iron abnormalities. Then we have hematopoietic stem cell transplantation. And lastly, we have gene therapy. We do this gene therapy using a virus called lentivirus. It introduces the functional beta globin gene into the patient. Now let's learn about alpha thalassemia. Its severity depends on how many genes are being deleted. Less number of alpha genes means increase in the number of free beta or free gamma genes. Okay, now this free beta or gamma genes form tetramers. When gamma chains form the tetramers in fetus, it is known as hemoglobin barns. And when beta chain forms tetramer in adults, it is known as hemoglobin H. However, this tetramers bind oxygen very tightly and it do not release the oxygen to the tissues. Hence, tissue hypoxia commonly occurs. Now let's look into the type of alpha thalassemias. There are 4 types. The first one is the silent carrier. In this type of defect, only one gene is deleted and hence it is completely asymptomatic. It has normal RBCs and the factory runs smoothly. The next type is alpha thalassemia trait. In this defect, 2 genes are being deleted and it can be either of the cis type or can be of the trans type. This one shows mild anemia which can be of microcytic hypochromic type and it shows no abnormal physical signs. The next one is hemoglobin H disease. In this defect, 3 genes are being affected. So only one gene is working, and the decrease in the number of alpha chains will lead to the increase in the number of free beta chains. And this forms tetramer of beta chains known as hemoglobin H. However, it leads to poor oxygen delivery, tissue hypoxia, and this intracellular inclusions will lead to red cell damage, and ultimately it will cause anemia. The last one is hydrops fetalis, where all the alpha genes are deleted. So there is no alpha chain, and there will be an increase in the number of free gamma chains. These gamma chains will aggregate and form tetramers known as hemoglobin bars. This will lead to severe tissue hypoxia, heart failure, generalized edema, which is known as hydrops, and this disease is fatal for the fetus. Now let's look at a diagram from Robbins. See, if there are no mutations and the synthesis of adult hemoglobin is fine, then we will get normal red blood cells. But if there is reduced beta globin synthesis, then relatively the number of free alpha globin chains will increase, and this will accumulate inside the RBC precursors and form an abnormal erythroblast. And when these abnormal red cells leave, they form hypochromic red cells with alpha globin aggregates. Now during extravascular hemolysis, they are destructed by the spleen and it forms anemia. Now there is also ineffective erythropoiesis, and most of the erythroblasts die during their formation in the bone marrow. Now this also leads to anemia. So ineffective erythropoiesis and extravascular hemolysis both are responsible for anemia in thalassemia. Now this anemia will lead to tissue hypoxia, erythropoietin increase, and marrow expansion, which will lead to abnormal skeletal deformities, right? Now the patient will require constant blood transfusions, which will lead to systemic iron overload or secondary hemochromatosis. Also, due to ineffective erythropoiesis, hepcidin amount is decreased and the inhibitory effect on iron absorption is decreased, so iron absorption will be more and more. And this excess iron will deposit and affect the heart and the lungs mainly. So that is all about thalassemia. Now you can go and read the same chapter from Robbins. I have included most of the information from the book, and I have tried to make it as simple as possible. So just go and check it out. And that was all about thalassemia.